Dr. Rahmi Mowjood, Chief Executive Officer and a shareholder at Cucamonga Valley Medical Group, and Dr. Kyle Smart, Chief Medical Officer and also a shareholder at CVMG, have agreed to a series of interviews to connect the dots tied to all the information out there related to COVID-19. Cucamonga Valley Medical Group sees this as an opportunity to be a resource for patients, their families, other providers, and the community. Dr. Smart, let's open with you.
Thanks, Dave. There's so much information coming out about COVID-19. There's a lot of uncertainty around there, and there's a leadership opportunity from the government and from healthcare organizations to help coalesce some of that. That uncertainty can create anxiety and fear, and there's really an opportunity to walk people through a process and connect some of those informational dots, and show the why behind some of the decisions and the behaviors happening right now, so that we can see how we can positively impact this COVID-19 pandemic.
Yeah, I think to build on that, Cucamonga Valley Medical Group has prided itself on really trying to do everything we can to help communicate to our patients in general. It's part of our core culture of life, love, and compassion. And I think in this crisis, more than ever, we need to really work on communicating and being as forthright as possible with whatever information we can that can help patients. So I think that as we look at what we can do, these videos are a way that we can help people digest some information that kind of is all over the place and bring it down into a simple, more local level. I think that's the key here. This crisis is going to get conquered locally. There is national edicts and such, but if locally we work together, then we will create areas where we are conquering what's happening around us.
You both have talked to me about an interesting take that you've done where you've gone back and looked at history, some as recent as about 10 years ago, and then some like almost 100 years ago. Talk a little bit about what that history does to help us to understand today.
I think that from a historical perspective, the last time we kind of looked at something that was similar to this, maybe not as extreme, was around 2009. And Dr. Smart and I were asking each other, what were we doing in 2009? Cucamonga Valley Medical Group was very much in its early years, and we were working through the struggles of the recession. And the flu pandemic at that time was not so much a pandemic as it was H1N1 came about. And similar to COVID-19, H1N1 was an offshoot of the influenza virus that we had never seen before. And that created a large number of fatalities, that created the need for a separate vaccine, that created a need for people to be more aware and careful. COVID-19 is a little different in that there's an aggressive nature to it that we're seeing in days and weeks of the initial exposure. And historically, it's helpful for us to look at that to see what can we learn from that. And we can look further back. You can look at the flu pandemic of 1918 to 1920, but there's a level of immunity that has built up over the generations because of that. So it has been helpful to sort of just glean from the more recent one in 2009.
Dr. Smart, you had pointed out before we went live with the video, some stats that surprised you from 2009 that actually are bigger than a lot of people realize.
Absolutely. I think just the way my mind works, it helps me to get some perspective from the past. And in 1918, there were actually 3 waves of infection over 1 year, from the spring of 1918 to the spring of 1919. Globally, 500 million people were infected, 50 million deaths. That's a 10% fatality rate. And there was 675,000 deaths in the United States. Obviously, that was 100 years ago, like we've said, but more recently in 2009, another H1N1 influenza pandemic that went from about April 2009 to April of 2010. In the US, 60 million infected, 274,000 hospitalized, and 12,000 deaths. And like Rahmi said, we were like, what were we doing in 2009? Because I don't remember a lot of what's happening right now around COVID-19 happening at that time. I was working in our local ER. urgent cares, young children, and I don't think it's totally accurate to compare 2009 to currently, but it's important to take lessons learned from 2009 and how we can apply them today, because the viruses are totally different. One's obviously an influenza, one's a coronavirus. This coronavirus is way more infectious. The R naught, or the person-to-person infection rate for this coronavirus, is about 2.5 to 3.5, and influenza is about 1.3, 1.5, meaning an infected person will spread it to 2.5 to 3.5 other people in regards to COVID-19, which makes it much more contagious. Whereas influenza, if somebody has it, they're going to spread it only to about 1 to 1.5 other people. Also, COVID-19 is attacking a totally different demographic. It's attacking our older population, whereas that 2009 pandemic, it impacted younger people and children.
And I think also it's important when you're talking about R naught, where have we seen aggressive infectious agents in the past? And the measles epidemic comes to mind.
Right.
And if you look at data about the R naught as it relates to measles, it's much higher. Thus the need for ongoing vaccinations for all the infectious agents that we are subjected to. COVID-19 right now is what we're most pressing about and worried about.
So for the average person, the R naught, they're not even sure, what that means and how that relates. The biggest takeaway is that COVID-19 is much more contagious, or spreads much more than others.
Yeah, I think that as we're looking at the rates of infection in various countries around the world, the doubling rates, there's definitely a higher infectious rate compared to some of the other infectious agents that we're used to seeing. Is it the most infectious? No, not from what we've seen historically, but because COVID-19 is something new, because it's not something we've been exposed to, it is a coronavirus, but the strain is something that we have not been exposed to. Our bodies have not been able to build up an immunity. So it is creating much more havoc than a simple coronavirus that we've been accustomed to being exposed to.
I think the takeaway point is what you said, Dave. Compared to the annual influenza we get, the R naught of COVID-19 is about 2 times or more that of the influenza virus.
Dr. Smart, you've written extensively on vaccines, and you've also talked about that on some of the other videos that we've all been working on together. Talk a little bit about the vaccine situation, the potential there, and some of the other statistics that you walked through when you and Dr. Mowjood and I have been preparing to try to figure out what's the best way to get all this massive amounts of information out to the community.
Yeah, the vaccine article that we worked on, from 2015, what I was really trying to do in that article was show how vaccines work. And we looked at yellow fever, we looked at measles, because there was an outbreak recently. We looked at a few other historical infections. Diphtheria was one of them, and the story of the sled dog that got the diphtheria antitoxin out to the remote part of Alaska, and just how we are standing on the foundation of the work of vaccinations. And I thought if we could just show that historical perspective, vaccines have done their job, and a lot of vaccines have quelled, and we don't worry about them like in days past, and that might help show the perspective of that, why vaccines work and why they're medically recommended. And here we are living in a now epidemic that's gripped a pandemic that's gripped the world, and now more than ever, I mean, if we had a vaccine that could expedite this whole process and help with herd immunity, if we had a vaccine for COVID-19 that could expedite that herd immunity and get us back to our normal life, that would be such a wonderful opportunity and blessing.
Well, why don't you both jump in and talk about that? We hear all these terms, and herd immunity is one. Explain what that means in realistic terms, because that's the whole goal of these videos, is to talk in real straight talk to people so they understand it. If you could both just chime in a little bit, what are your thoughts on herd immunity? How do we get there? Why is it needed? What are the thoughts about that?
So if you look at, and this has been visualized, I think, over and over in the past few weeks, if you look at that flatten the curve graph, you'll see the typical epidemic curve. That epidemic curve peaks and then it eventually slopes down. Now, the assumption is that at some point in time, the virus will burn itself out. Either the number of people that get sick starts to dwindle, the number of hosts that are available are no longer available, or the number of people that have been around the virus eventually starts to build up some level of passive immunity and it starts to drop. The problem with that flatten the curve is that it goes far beyond the ability of the healthcare system to manage the number of sick patients. And that can create a huge crisis. And to be quite honest, we're already seeing that. If you're talking about saturated markets, look to New York and look to what's happening in New Orleans and other parts of the country, as well as other parts of the world. The healthcare facilities are overwhelmed. They're more than saturated because we don't have that ability to have that immunity. It's such a new and novel exposure to us.
Dr. Smart, what's the stats that you were talking about earlier about what we have to get to achieve the herd immunity?
Right. So I think in a nutshell, herd immunity is when a significant percentage of the population becomes immune to an infectious agent such as COVID-19, either through vaccination or people getting infected and then recovering. And so if a significant percentage of the population gets to that point, it protects the other people that haven't got infected yet. And the current epidemiologists and infectious disease specialists are suggesting, based on the R naught of COVID-19 being between 2.5 and 3.5, we need to get to about 60% of the population to have developed an immune response to this in order to get to herd immunity. And then we'll start to see that epidemic curve peak and then start to come down.
Dr. Mowjood, you talked a lot about how this really has to be a human issue, not anything more than that. And you've been passionate about that because there's confusion, there's a lot of passionate people talking about this. Talk about how you believe it's really about the human element.
Yeah, Dave, I think that, we all have a perspective on life and we all look at things, and there are people that are passionate about this issue and they're passionate on both extremes. So you have people on one extreme that might be a little bit more lax than maybe we might be comfortable with at the moment. And they're advocating, no, it's just a mild flu, go back to work, you should be fine. And then you've got people on the other extreme that are advocating extreme isolation and extreme sterility and really avoidance. There is no politics here with regards to what we're dealing with. We're not trying to politicize anything. What we're trying to do is remember what I brought about earlier on, that if you look at the local level, this is, and you grow that, this is a human issue. This is an issue that is related to our grandparents not being able to be with our grandchildren. This is our parents not being able to live our lives, our immunocompromised patients not being able to function without fear of getting sick. There are patients that are having chronic medical illnesses that they are managed and they found a way to deal with, and now they're afraid because they don't know what is around the corner. We have to start looking at this from a human perspective. And I know that might seem very simple and straightforward, but we get lost with all of the information that's out there. We get lost as we try to connect these dots and we try to make sense of what people are saying and what should you do and is there toilet paper available and things like that. What we're trying to do is we want people to maybe scale back and just take a deep breath and look and see what you have around you and look and see what you can do to help your family. Look and see what you can do to help and stay within the parameters of the social isolation, the distancing that we're talking about, because we are seeing that it is working, right? We are seeing in countries that have really employed these measures to a finite amount of people, it's working and it's keeping things under control, and the number of people are reducing that are getting new infections. You can't do that if you try to paint this with a big broad brushstroke. You have to look at it in a smaller subset and try to find a way to really deal with each community and help each community one by one. And if you look at it from that human perspective, then we can start to make some progress.
That's Dr. Rahmi Mowjood, the Chief Executive Officer and a shareholder at Cucamonga Valley Medical Group. Also, Dr. Kyle Smart, the Chief Medical Officer at Cucamonga Valley Medical Group. This is one of many Zoom video conferences CVMG is sharing to help educate us all. You are living your core values of life, love, and compassion. And I want to thank you both, and we'll be coming back with much more details on the next episode. We're trying to keep them all condensed to around 10 minutes. The next episode, we'll dig deep into those stats he mentioned about how it's working at certain countries and how we want to get there here in the United States and worldwide. Thank you both.
Thank you, Dave.
Thanks, Dave.